So this is a phase 2 trial presented at Lugano meeting by Mark Roszkewski from the National Cancer Institute of Bethesda. Is a multi-center study of the American group that assessed the safety and the efficacy of a combination called TEDDI-R, that is Temozolomide, Etoposide, Liposomal Doxorubicin, Dexamethasone, and RITUXIMAB for secondary CNS lymphomas. So there are a few ongoing prospective trials on secondary CNS lymphomas conducted in Germany, Italy, and Netherlands. And the results by the moment are very poor. The only multi-center international trial reported in the literature regards the Marietta study. The Marietta study include a treatment for patients with central nervous system dissemination, both at presentation and at relapse, with 3 courses of matrix, followed by 3 courses of rice and autologous stem cell transplantation. The only patients with secondary CNS lymphomas that are cured in the literature were treated with autologous transplantation. And another important concept is that the patients treated at initial diagnosis exhibit a significantly better prognosis with respect to patients with isolated or concomitant relapse after R-CHOP in particular. Some genetic analysis demonstrate that there are subtypes of diffuse large B-cell lymphoma with a higher risk to disseminate in the central nervous system. In particular, the MCD subgroup, which is characterized by mutations in the MYD88 gene and the CD79B. And as you know, this subgroup of lymphomas in general are those more responsive to BTK inhibitors, in particular to Ibrutinib. You perfectly know the role of Ibrutinib. Then the researchers thinking about a prospective trial that include the treatment with Ibrutinib for 2 weeks, and then according to the response, there was a response adapted with a patient who achieved a response of 20% or more in the measurable disease that received 2 different regimens. The first one is the arm 1 with Ibrutinib for 21 days, and the arm 2 with Ibrutinib for 10 days. For the patient who experienced a lower response, the Ibrutinib was interrupted, and patient proceeded with the TEDDI-R treatment for 4 courses. This is the TEDDI regimen with the inclusion of Temozolomide, Etoposide, Liposomal Doxorubicin, Dexamethasone, RITUXIMAB, and intrathecal chemotherapy. Importantly, in this regimen, as used also, for example, at our institution, these patients were, the antifungal prophylaxis was based on isavuconazole, because the other prophylaxis, the more conventional fluconazole and voriconazole, are not effective to reduce the risk of aspergillosis, lethal aspergillosis associated with Ibrutinib, in particular in patients who receive steroids for different weeks. 52 patients were screened, 50 patients were enrolled, 43 patients were assessed for the response to Ibrutinib, and there were 18 Ibrutinib non-responders. and 25 Ibrutinib responders. These are the characteristics of the patients. Importantly, it's evidence that 1/3 of the patients were 70 years old or older. 1/3 of the patients had a high-grade B-cell lymphoma, in particular with MYC and BCL2 rearrangements, and 56% of the patients had a synchronous peripheral or systemic and CNS dissemination. And the vast majority of the patients were refractory to prior treatment. The treatment, the tolerability was acceptable. There were not signals of feasibility regarding the Ibrutinib. This is the toxicity. As you can see, there were a few cases of grade 4 toxicity, and there was a single case of grade 5 toxicity to Ibrutinib. This was due to a lung infection, probably an aspergillosis activation. These are the responses to Ibrutinib. Most of the responses were observed in non-germinal center diffuse large B-cell lymphoma, which are a large proportion of patients with secondary CNS lymphomas. The response of Ibrutinib was observed in the different subtypes, but in particular in ABC. Less frequently, as you can see, in the unclassified, and the duration of the response to Ibrutinib was important, with some of these patients with a response maintained for more than 2 years. Conversely, in the cases that were not responsive to Ibrutinib, there was a very, very fast early progressive disease. This is the progression-free survival curves for all the patients. At 1 year was 38%. This is very, very similar to those observed with the Marietta trial. And is similar also, the 1 year overall survival, close to 60%. The response to Ibrutinib was an important predictor of the progression-free survival and also of the overall survival. Because it's important to underline that a few patients were treated at presentation and then were untreated patients. In this study, we confirmed very similar figures like reported in the Marietta trial, with good progression-free survival in patients treated at presentation with respect to patients treated at relapse. An important contribution also of this study that deserves to be assessed in other series is the predictive role of the CD10 expression. In these patients, the positivity of CD10 was associated with a poorer progression-free survival with respect to the others. Probably there was, this is explained because there was a higher response rate in patients with CD10 negative lymphomas. In conclusion, Ibrutinib responsive lymphomas involving the CNS achieve high rates of complete response to TEDDI-R. Some of the responses can be durable, and the regimen was safe in most of these patients that were refractory to prior treatments. Most ibrutinib responsive tumors do not express CD10 that should be investigated as biomarker to select patients for this combination. And this is to thank the researchers, in particular Dr. Roszczewski, who shared with me this important information. And thank you for your attention.